Welcome to my channel. In this video, I will discuss what is Merengotomy in detail. So, Merengotomy is a small incision that is made in the eardrum. Here you can see a small incision made in the eardrum. I have told you that it is a surgical procedure in which a tiny incision is created in the eardrum, also known as tympanic membrane, and it relieves the pressure that is caused by excessive buildup of fluid in case of otitis media. Sometimes a tympanostomy tube is inserted into the eardrum to keep the middle ear aerated for a prolonged time and prevent reaccumulation of fluid. Now we will discuss some history of Merengotomy. In 1649, Jean Rollin the Younger accidentally pierced a patient's eardrum while cleaning it with an ear spoon. Surprisingly, the patient's hearing improved. There are also some reports from 17th and 18th century describing separate experiments exploring the function of the eardrum. So, Merengotomy was discovered accidentally. The animal experiments of Thomas Willis, a scientist, were expanded upon by Sir Ashley Cooper, who presented two papers to the Royal Society in 1801 on his observations that Merengotomy could improve hearing. First, he showed that two patients with perforations of both eardrums could hear perfectly well, despite conventional wisdom that this would result in deafness, because at that time people think that if tympanic membrane or eardrum is damaged, then it can lead to deafness, but it was not true. Second, he demonstrated that deafness caused by obstruction of the Eustachian tube could be relieved by Merengotomy, which equalized the pressure on each side of the tympanic membrane. So what are the indications for Tempenostomy? Indications for Tempenostomy are chronic otitis media with effusion, which is unresponsive to antibiotics. Recurrent otitis media in adults and includes Eustachian tube dysfunction, which with recurrent signs and symptoms like fluctuating hearing loss, vertigo, tinnitus, and severe retraction pockets in the tympanic membrane. These retraction pockets in the tympanic membrane can lead to cholesteatoma. Recurrent episodes of barotrauma, especially with flying, diving, or hyperbaric chamber treatment, may merit consideration. Now we come to procedure. How Merengotomy is done. It is usually performed as an outpatient procedure. Generally, anesthesia is preferred in children because these children are not cooperative, while local anesthesia suffices for adults. Ear is washed and a small incision made in the eardrum. Any fluid that is present in the middle ear cavity is then aspirated and the tube of choice is inserted, and the ear is packed with cotton to control any slight bleeding from the ear. This is known as conventional Merengotomy. It heals in 1 to 2 days. A new variation called Tympanosclerostomy or laser-assisted tympanostomy uses carbon dioxide laser and is performed with a computer-driven laser and a video monitor to pinpoint a precise location. Mostly for precise surgery, we use carbon dioxide laser. The laser takes 1/10 of a second to create the opening without damaging surrounding skin or any other structures. And this perforation remains patent for several weeks and provides ventilation of the middle ear without the need for tube placement. So in this procedure, tube placement is not required. Though laser merengotomies maintain patency slightly longer than cold knife merengotomies, they have not proven to be more effective. in the management of effusion. One randomized control study found that laser merengotomies are safe but less effective than ventilation tube in the treatment of chronic otitis media. Multiple occurrences in children, a strong history of allergies in children, the presence of thick mucoid effusions, and history of tympanostomy tube insertion in adults make it likely that laser tympanostomy will be ineffective. So these conditions are responsible for ineffectivity of laser tympanostomy. Various tympanostomy tubes are now available, and traditional metal tubes have been replaced by more popular silicon, titanium, polyethylene, gold or stainless steel or fluoroplastic tubes. Now the latest tubes are coated with antibiotics and phosphoryl choline. What types of incision we give in merengotomy? First one is cutting type, given in posterior inferior quadrant, and it is done in cases of acute otitis media. So it is done in posterior and inferior quadrant. Splitting type, given in anterior inferior quadrant, this is done in cases of serious otitis media. Anterior inferior quadrant, splitting type. It is more suitable for grommet insertion. Incision is either J hockey shaped or curvilinear shaped, that is given from below upwards so as to ease the drainage. It may be J or hockey shaped. So what is the safety after? What is the safety required after merengotomy? A single randomized trial found statistically benefit to using ear protective devices when swimming, although the size of the benefit was quite small. In the absence of strong evidence, general opinion has been against the use of ear protective devices. However, protection such as cotton covered with petroleum jelly, ear plugs, or ear putty is recommended for swimming in dirty water, lakes, rivers, oceans, or non-chlorinated pools because these can lead to infections. For bathing, shampooing, or surface water swimming in chlorinated pools, no ear protection is recommended nowadays. What are the complications? Any surgical procedure can lead to complications. So the placement of tube is not a cure in case of otitis media. If middle ear disease has been severe or prolonged enough to justify tube placement, there is a strong possibility that the child will continue to have episodes of middle ear inflammation or fluid collection. There may be early drainage through the tube otorrhea in about 15% of patients, tube otorrhea, and developing in 25% more than 3 months after insertion. Otorrhea is considered to be secondary to bacterial colonization. The most commonly isolated organism is Pseudomonas, methicillin-resistant Staphylococcus aureus, etc. Some practitioners use topical antibiotic drops in the post-operative method to prevent these complications. But research shows that this practice does not eradicate the bacterial biofilm. A laboratory study showed that tubes covered in the antibiotic vancomycin, antibiotic-coated tubes, prevent the infections caused by these organisms. Phosphorylane-coated fluoroplastic tympanostomy tubes are also used that are showing no statistically significant difference in the incidence of post-operative otorrhea, that is tube blockage or extrusion. So these are the complications of merengotomy. Thank you for watching.